Hello everyone. So today we shall look at this interesting topic we call anetoderma. I'm Dr. Abraham from A&E dermatology specialist. So anetoderma simply means laxed or relaxed skin, usually due to loss of skin elasticity. When you damage the elastic component of the skin, you call the elastic fibers. So this condition was first described by a gentleman we call Jederson in the 1892. And this word comes from two Greek words, the first one being anetos. Anetos simply means relaxed. And the second word is derma, which simply means skin. So in this case, someone will present with well circumscribed flaccid skin areas, and because of this, the picture will give you atrophic depressions, which can be macules, which can end up appearing like animation sacs on the skin, and they'll be protruding through the skin. And these lesions can vary in color, but most times they are a little bit skin colored. But we've seen a few cases where they are hypopigmented or even hyperpigmented. Some of them can appear whitish, grayish, brown, or sometimes even blue. So the most common location includes the trunk, the proximal extremities, and this is a very, very chronic condition, and sometimes it doesn't resolve spontaneously, or even with treatment, it doesn't resolve. So the etiology or the different causes of anetoderma have been classified into five groups, whereby we have the primary, which we also call idiopathic. So previously, under primary, we had two, the Jederson type and the Schlesinger type, but currently this classification has been phased out. So under primary, we just say it is primary anetoderma or idiopathic anetoderma if you're not able to identify a cause. So if you're not able to identify a cause, then we call it the primary anetoderma if there is no cause. And then it becomes secondary if it occurs or it is preceded with the different dermatoses, which can either be infectious or inflammatory. So under infectious, you can have things like acne, which are infections like varicella or even syphilis. And then under the inflammatory but non-infectious, we can have things like granuloma annulare, we can have things like systemic lupus erythematosus, and the rest. Then we have the third class we call drug-induced anetoderma, and in this case, there's only one drug that has been isolated to cause this condition. We call penicillamine. So people on penicillamine can end up developing anetoderma-like lesions on the skin. The fourth category, you call it familial. In this case, it has autosomal inheritance, and oftentimes, in this case, it presents early in childhood, and it has been shown to occur even in twins. And the other last type, the fifth one, we call it prematurity associated anetoderma. And in this case, it occurs in the preterms that are born within 24 trillion weeks of gestation. And usually this one comes in a little bit early in life, and it usually persists for a longer time. So the epidemiology, we don't know the exact prevalence because it is a very rare disorder, and even in research it hasn't been well described. So the common age group of onset is about 20 to 40 years, but we've seen it presenting as early as the 1 week after birth, especially in the preterms. And it has a slight prevalence, which is slightly more in females compared to males, but there's no racial predilection. So it affects people from all races, be it African Americans, be it the Caucasians, or even the white population. So the pathophysiology or how it comes about, currently there's no particular way that has been described the pathogenesis of this condition. However, it has been attributed to the possibility of a decrease in the elastic tissue. But however, how this comes about, it is not yet certain. So because of this, it can occur either you have decreased production of elastin or increased degradation of elastin. And this has been postulated that we have elastolytic enzymes that end up breaking down elastin, and they're overexpressed, so you end up with loss of elastic tissue. However, in the cases of penicillamine, we saw that penicillamine interferes with the aldo cross-linking, and this is a very key step in synthesis of elastic fibers. So because of this drug and how it acts on this process, you end up not being able to form elastic fibers, so you end up with anetoderma. And in neonates, it has been associated due to tissue hypoxia, which comes with prematurity, and as well as adhesive devices usually put on these neonates, the monitoring equipment, the electrodes that are usually put on these neonates. They think these electrodes can increase the degradation of elastin and the skin. Then you end up with anetoderma. Then, histopathologically, if you take off a sample, you have marked loss of elastic fibers, especially in the papillary and the reticular dermis. And in this case, sometimes you will see infiltrates of histiocytes and plasma cells, especially around the blood vessels. And if you are to look at this slide under electron microscope, you will see phagocytosis occurring, and also fragmented elastic fibers will be noted on electron microscope. But this can be done on routine, so it is just an experimental procedure or test that can just be done to confirm the diagnosis, but it is not used on routinely. We can also use the stains for elastin. For example, we can use the desmosine stain, and in this case, it will be reduced in lesional skin compared to the normal surrounding tissue. The clinical presentation, sometimes these lesions present as asymptomatic or slight epiretic markings or papules, or sometimes even nodules. And usually they'll keep on enlarging until when they will reach their final size. And after this, you see flaccid or wrinkled skin, sometimes depressed, sometimes even bulging because of the weight of the structures like fat. They can end up presenting as bulging or nodules on the skin. And when you palpate in these areas, you will see that there is some bit of herniation of the underlying tissues, which can be either reducible, like when you palpate, the lesion is able to go inside. When you remove your hand, then it comes back. Then lesion stability, usually after over time, these lesions don't change. They remain the same. If they are fully developed, they don't change over time. So it will be more or less constant. Then in the diagnostic evaluation, in this case, if you're not certain, but this diagnosis can be made clinically, but if you're not certain, you can take off a biopsy. And in this case, when you're punching, you have to punch where the lesion is. For example, if this is your lesion, you punch the lesion plus the surrounding skin. So if this is normal skin, and if this is lesional skin, so you punch part of the lesion plus the surrounding skin, so that when they section, you get a picture of how the normal skin is compared to the lesional skin. Then you can do the desmosine testing, which is will be reduced in case of elastic tissue involvement. Then it oftentimes will also encourage, if it is primary or idiopathic, you have to do antiphospholipid antibodies, and in this case, you have to make sure if the patient is female, then you have to look out for spontaneous abortions, because we know antiphospholipid antibodies are seen as one of the implications in spontaneous abortions. So the treatment is a little bit difficult and very hard to manage because in this case, we don't have a well-established etiology, and actually even the medication, you cannot treat you cannot treat something that you don't know what is causing the cause is. So in primary anetoderma, the trial drug is colchicine, which tries to prevent actually development of new lesions, but it has nothing to do with already established lesions. And then in secondary anetoderma, you have to treat the underlying dermatosis, if it is varicella, if it is syphilis, so that you prevent progression. Then other drugs that have been tried in different case reports includes phytotherapy, intraregional steroids, even oral steroids, hydrochloroquine, vitamin E, laser treatment. All these have been attempted, including surgical procedures like excision. However, this also leaves a scar, and then the patient, you have to wait between the primary lesion that is there and then the scar. And sometimes it is very, very extensive, covering the entire truncal limbs. And how would you operate and leave the person looking like? So sometimes it becomes very, very hard to manage. And sometimes you may end up just canceling the patient, and that's it. So you can see in this picture, for example, here uh, we see this laxed skin on the chest wall. We see the same picture here. So this is now what we call anetoderma. And then you see also this wrinkling of skin almost all over the body of this neonate. So in the differential diagnosis, these are the things that can look like anetoderma, and they include mid-dermal elastosis, and in this case, you'll have loss of elastic fibers, especially in the mid-dermis, which will give you wrinkling, and it will give you this plaques. So the other differential would be the acquired cutis laxta, which, but in this case, if someone have a widespread sagging of the skin due to a loss of elastic tissue, and someone will appear more old or elderly, it will have that aged skin. So a child is around 15 years, but when you look at them, they look 8 years. Another differential is glomerular slack skin. In this case, usually it is due to cutaneous T-cell lymphoma. And another one is the atrophoderma of Pacini and Pierini. In this case, you get gray or brown patches with distinctive borders. So as you can see in this picture here that you see, so all this skin here is laxed and very, very soft and with wrinkling. So that's what we call anetoderma. So the prognosis, lesions usually remain stable, even permanent for eternity until when you die, and there's no spontaneous resolution. And we have complications that can come with anetoderma. These ones, inputs thrombotic events have been reported as superficial phlebitis, sometimes spontaneous abortion if the patient is female, especially if it is associated with increased levels of phospholipid antibodies. So in summary, anetoderma is a little bit a rare benign condition that causes flaccid areas on the skin, and it is classified depending on either the cause, that being the primary, if you don't know the cause, is also called idiopathic. Secondary, if it's taken through dermatosis that are identifiable. Drug-induced, if the patient is on penicillamine, it can also be familial or associated with prematurity. Then there is no curative treatment, but however, you can try colchicine to prevent new lesions, especially if you classified it as primary. And then if you can identify an underlying cause, you can treat it. And then you have to screen the patient for antiphospholipid antibodies and caution them about spontaneous abortions if they are female. Thank you very much. I'm Dr. Abraham from A&D Dermatology. See you in the next video.